this morning we talked about the partnership between ophthalmology and optometry. And this afternoon, we're going to explore a little bit about also partnering with machines. We've alluded a little bit to this morning about how difficult, how much data there is for glaucoma specialists to assimilate. And it seems like artificial intelligence can help us with this. And that's what we're going to explore this afternoon. I'm joined by my co-moderator, Josh Stein, who's from the University of Michigan and is an expert on big data. And he's going to give some introductory comments to introduce the concept of artificial intelligence and large language models. Take it away, Josh.
Well, thank you very much for inviting me to speak, and kudos, Lou, to you and Bob and Murray for putting together such a fantastic session today. I'm going to give an overview of large language models in ophthalmology, and I have no relevant financial disclosures. So I'm going to start by just sort of giving a high-level overview of the different types of, I would say, machine learning, deep learning, modeling out there. And this table does a nice job of kind of summarizing the key similarities and differences. So all of this is machine learning, but within machine learning, you've got deep learning, which is a subset that usually uses artificial neural networks to perform tasks. There are different architectures. These are usually done either semi-supervised or unsupervised. There's GPT, which is a type of deep learning that uses large language models that are transformer based for language tasks. And then there's Chat GPT, which is a form of GPT that's more conversational. In terms of the inputs, for deep learning, it's more variable. It can be unstructured data, it could be tabular, it could be images, whereas with GPT and Chat GPT, it's primarily text that we're dealing with. With deep learning, usually you're feeding in a data set, whereas with GPT and Chat GPT, there's pre-trained on large volumes of textual data. That the deep learning is usually one task at a time, whereas with these others, we're able to do multiple tasks with high alignment, and then interactivity is not present with deep learning, but with GPT, there's some interactivity. With Chat GPT, there's a lot of interactivity, so it's almost human-like. If we look just at some of the large language models, like GPT-4, you can see how it's able to do a lot of tasks such as common sense reasoning, both based on knowledge and context, sentence completion tasks, reading comprehension, grade level mathematics. More recently, researchers have used these tools to take the USMLE test, for example, and the performance was actually quite well. Here, this research group looked at large language models to see how they would do on American Board of Ophthalmology style questions. And you can see the overall success was about 72%, which was comparable to humans. And in the glaucoma area, you can see also nearly identical to humans. The areas that it didn't do so well were, tabulations and optics. Here you can see from that same study a bunch of the details of which sorts of questions the Chat GPT did well and poor relative to humans. And you can see for single-step questions, for questions that are very science-based or workup or management, they did quite well relative to humans, but other questions that either involved image interpretation, calculations, multi-step, or just simply more difficult questions similar to the human test takers, the machines also struggled. In terms of use cases in ophthalmology, this sort of shows the clinical workflow of how patients kind of come through our clinics. And there are different areas that researchers have found where these large language models can be useful. So one would be in triaging patients. So, risk stratification, figuring out which patients need more urgent appointments versus less urgent appointments, triaging in-person versus virtual visits, which types of patients can be managed by lower level providers versus subspecialists, glaucoma subspecialists like ourselves. Another use case is personalization of patient visits, figuring out the optimal sequence of what types of tests a given patient may benefit from in the ordering of those tests, doing intelligent scheduling of appointments, automated completion of forms. If you have patients that need to go to surgery, helping with pre-op questionnaires to see who's a low or high-risk surgical candidate, enhancing patient enhancement. So being able to take the diagnoses and the therapies and frame the information in a manner that's tailored to a patient's health literacy, their spoken language, assisting patients with understanding the importance of adherence with topical medications, and helping answer questions in between in-person clinic appointments. On the provider side, there are also use cases helping with EHR documentation in terms of crafting consultation notes, operative dictations, discharge summaries, helping with proper billing to maximize reimbursement, summarizing large volumes of past medical records for a patient who's new to our practice to just get us what we really need to know to be able to take care of them. And then in terms of improving education of our trainees, being able to summarize huge textbooks and really distill down to the most important material, and also help with real-world interaction with patients in terms of role-playing with our trainees to help make sure that they understand how to competently handle certain situations. Specifically in glaucoma, there are a few publications that have come out so far. One, a group used large language models to help enhance patient education material about childhood glaucoma. They noticed what's available online was of poor or moderate quality, and they were able to use GPT to improve the quality of the existing material, or even come up with new material that's of better quality. Was a study comparing performance of Chat GPT to ophthalmology residents, and it did as well as third-year ophthalmology residents. There's another study that the next speaker will be talking about that did a comparison of Chat GPT to attending ophthalmologists. And then there's also a study that recently came out looking at decisions for laser or incisional surgery, and found that the large language model was recommending the same surgery as a glaucoma subspecialist about 60% of the time. There are some challenges with large language models in ophthalmology. I don't have much time to go into a lot of detail on this, but there's concerns about patient privacy and cybersecurity concerns. All this data needs to be, accessed and compared to do the modeling. So it needs to be HIPAA compliant and PR compliant, and that sometimes can be tricky. Right now, these models tend to do very well with text, but they're not very multimodal. So we do a lot of image analysis, a lot of fundoscopy. Hopefully in the future, there'll be ways to incorporate those types of information into the models, but right now, not so much. There are these issues with what are called hallucinations. The models are primarily being trained on a large corpus of public data on the internet and not specialized ophthalmic data. So sometimes the models can come up with answers that are just not factually correct. There are legal and ethical considerations. Who's liable if the model provides erroneous advice? Should patients be notified every time their medical data is accessed by one of these models? And then there's a lag in the ability to consider advancements in the field. This paper by Huang's group that does a phenomenal summary of the existing literature on large language models in ophthalmology. So I would highly recommend if you want to learn more to look at that. There's also an interesting study. It's actually a short 3-page paper in Nature, trying to better understand what's going into the decision-making of these models. And they're trying to use explainable AI to help reverse engineer to try to understand how the models work. And they're actually tapping into the field of psychology and trying to ask the models to explain themselves. And, it's very interesting. Like one of the examples they talk about is they fed the model 12 questions in a row. These were multiple choice A, B, C, D questions, and all 12 of them, the correct answer was choice A. And then they asked a 13th question, and that one, the correct answer was choice C, and the model ended up choosing choice A. And then when they asked the model why it chose choice A, it didn't say it was because all the others were choice A, but it tried to come up with some, weird, convoluted way to explain why A was the choice. And they said it's really very similar to the implicit bias that we as humans do when we're doing like hiring and things like that. So I'm going to just give 2 quotes and then I'll stop here. This are both from this article. This is a computer scientist, David Bao. With conventional software, someone with inside knowledge can usually deduce what's going on. If a website's ranking in Google search goes down, we usually have a good idea why. Here's what really terrifies me. With the current breed of AI, there is no such understanding, even among the people building it. And another researcher from Germany said, it's nonsensical to think that these large language models have feelings. It's nonsensical to say that they're self-aware or that they have intentions, but I don't think it's nonsensical that these machines are able to learn or to deceive. So I'll stop there and turn over to our next speaker.
Thank you. So when I was an undergraduate, I was programming mainframe IBM computers with punch cards. It's amazing how far it's really our next generation of ophthalmologists who are going to show us the way on how we could potentially use the computer technology that we have. So I'm really happy that Annie Huang, who is an ophthalmology resident at New York Eye and Ear Infirmary, is going to continue this discussion on large language models and their utility in glaucoma management.
Thank you for that introduction and great overview so far from Dr. Stein. So I'm very honored and humbled to be speaking amongst, esteemed optometrists and ophthalmologists. And I hope that even though I'm a resident, that my brief talk here will at least shed some insights as to this hot topic of large language models and show some glimpse as to how this could be used in your daily practices or possibly reducing some activation energy for using this for your, at your home. So that's a chemistry joke there. So next slide. Oh, here. So, there is no doubt that ChatGPT, took the world by storm. Here, it's just two displays that demonstrate how rapidly ChatGPT has grown. So in just 5 days, ChatGPT grew to 1 million users. And that's the fastest growing application that has ever, existed in history until Thread came in July 2023, but that's largely due to its integration with Instagram. And for those in Generation X and baby boomers, those are social media platforms.
Thank you.
So yeah, it's incredible. It's estimated that ChatGPT now has 100 million monthly active users in January 2023. That's 2 times more than December of 2020, or December, the month prior. And 100 million active users in January 2023. That's so approximately 13 million users are now using it daily, and it's getting rapidly increasing. Especially with the new GPT-4o model that has just come out, it's only exponentially getting larger from here. GPT-4o is the free model that is also the most sophisticated model that's out there so far. And so this is just a little bit of an overview of large language models that Dr. Stein has already covered. So I'm just gonna basically gloss over this in the sense that from 1950s to the 2020s, there's been rapid changes in development of large language models. In 2020s, that's when GPT-3 and GPT-4 came out with very sophisticated ways of understanding text as well as images, and then the explosion of the subsequent large language models with Gemini and Claude and Llama from Meta. And then here again, I'm just going to gloss over it, but I just want to point out the parameters here. In 2018, there was 115 million parameters. And then now recently in GPT-4, and this is already outdated because there's a GPT-4o model, but there's 1.8 trillion parameters that has been used here. Okay, so you might be thinking, wow, it's another large language model study with similar results, but just hear me out here. So I was a fairly early adopter of large language models, with GPT first becoming publicly available in November 2022 when I was a intern at that time, and I was fascinated at how mysteriously good at what it did. And it was really helping me with my day-to-day. And so I ultimately, got really, curious about this. And then me and Dr. Pasquale kind of looked into this a little bit more. And, our paper here is titled Assessment of Large Language Models, Responses to Question Cases about Glaucoma and Retina Management. And, it was actually quite a provoking paper. It was published just 3 months ago, more or less, and got quite a buzz in readership, generated quite a buzz in readership with Dr. Chang from NYEE, as well as Dr. Eric Topol who's known for his genomics and digital data, tweeting about it on formerly Twitter, now known as X. So it's not displaying correctly here. But essentially, there's 2 components to the study that we did. The data collection, which was a series of randomized AAO questions that were essentially commonly asked questions, as well as 20 identified patient cases. There were 20 glaucoma cases as well as 20 retinal cases. So in total, there was 40 questions and 40 cases. And then we recruited 8 glaucoma attendings as well as 4 retina attendings who generated answers and full assessment and plans for all of these cases, as well as having GPT-4 create a similar assessment plan. And then the data analysis here on the right side, we then had these assessment plans that were created by these attendings, as well as GPT-4, be created into another questionnaire, and then blinded with subsequently more attendings, as well as a couple fellows and PGY4s that then rated them based on a Likert scale. And then this was then with data analysis with Mann-Whitney and Khosrowshahi-Wallace tests. Okay, so here, prompting, what I want to show here is essentially prompting is everything here in large language models. So there's like a whole field dedicated to prompt engineering to allow for the output for ChatGPT and these large language models to output with exactly what we want. So the prompt that I generated here, it took many trials and errors in order to produce exactly the same output that I would have created for an assessment plan that I would do in the clinic setting. And so here, the prompt essentially is saying, I'm an ophthalmologist, you're assisting me with medical management. This is a more condensed version, but essentially I want it to be concise as well as accurate. And then the bottom is just GPT giving me a generic response. So here we have a case one. I'm gonna first just talk about the case, and then there's a video that kind of goes into a live demonstration. Well, as live as we can get. I was hoping to have ChatGPT pulled up here and like type it myself, but a video will do. So it's an 80-year-old female with history of normal tension glaucoma and epiretinal membranes in the right eye on Cosopt and brimonidine and Zolotan eye drops. Vision is 20/25 and 20/20. IOP is 10/12, Tmax 18. No APD. Rest of the anterior exam is unremarkable with PCIOL, and the CCT is 571 and 602. Gonioscopy was full with disc of 0.8 and peripapular atrophy. And then the visual field does show that there is some periarcular defect in the left eye, and then the RNFL is 91 and 70. And so here's the video. So this is ChatGPT 4.0, and then first I will plug in a generic prompt, a prompt that I previously generated that I shown you earlier, and then GPT says it understands. And then the second part, I would then put in the HMP with the examination findings with the randomized patient that is de-identified. And then also the second portion, I gave a more specific instruction as to what I want from the assessment plan. And this is something that's also included in our manuscript and is publicly available. And as you can see here, an assessment plan is generated like how we would write in our EMR. And then I just was curious and wrote expand upon this in case any of you guys want more information about the assessment plan that that the more condensed version was shown above. So here, as you can see, the assessment, showing is saying normal tension glaucoma, stable IOP, and then it was saying continue current regimen, and then come back for IOP check, visual field, and OCT, and talk to the patient about medication adherence, and just any like return precautions, essentially. So, and that was just like a video that I created last night. First try, no cherry picking. And so this is what was generated for our manuscript as in our first attempt as well. The assessment, as you can see here, normal tension glaucoma, and then the plan here again, continuing eye drops, visual field, RNFL in 6 months, and adherence to medication. Interestingly, so for this specific question, the one that we give to all the attendings to generate their own assessment plan, as well as having then it be blindly rated on a Likert scale with GPT-4, the mean accuracy here was 9.25 out of 10 for GPT-4, and for glaucoma specialists, it was actually an 8.59. And then on mean completeness, it was 5.25 out of 6, and glaucoma specialists, it was a 4.86. That being said, there were 2 glaucoma specialists that scored higher with the highest mean accuracy of 9.5 and mean completeness of 6. So I just want to demonstrate one last case here. A little bit more complicated patient, but a 78-year-old male here with past medical history, chronic angle closure glaucoma, status post-LI in both eyes, cataract surgery, Kahoot goniotomy in the left eye, has a higher Tmax on alpha-GAN cosabzalotan Ropressa. And here the visual acuity is noted to be 2100 and left eye was hand motion. And here, anterior exam is unremarkable with pain LI, gonioscopy was fairly full, and cupping was 0.7 OU. And then here, the visual field showing inferior temporal islands OU and RNFL was 61 OU. And then here's a second video. Again, the generic prompt that I put in initially, as well as then putting in the HMP with the examination findings, and then a more specific instruction for the assessment plan. As again, you see here, I found that putting it together like this for the second part just gives it a more accurate assessment and plan. That's why I did it this way. So here, assessment, advanced chronic angle closure glaucoma, status LI, as we know. And then I'll click to the next slide. We can look at this in detail with the bigger picture. So here again, chronic angle closure glaucoma and cataract and decreased visual acuity right from left, cause to be determined. That part was interesting in the sense that there was a decent amount of subspecialty of ophthalmologists that might have kind of glossed over that detail where there was a decreased visual acuity that might have not necessarily corresponded with the visual field in the RNFLs, but the plans here, it says the GPT-4 model said to continue alpha-GAN, cosabzalotan, check IOP, visual field, and OCT in 6 months time. But then it did also mention to consider additional workup for the decreased visual acuity, possibly in OCT macula, FF or FA or console retina. And so here again, the GPT-4 had a slightly higher rating on the Likert scale with a mean accuracy of 8.29 as compared to 7.38. And then the GPT-4 model had a 5.14 as compared to 4.22. And again, there was one additional specialist that did score higher compared to GPT-4. So I'm not really going to go too in detail with this. This is the result from our paper here, but ultimately what we were trying to say is, what we were trying to understand was whether large language models can provide an accurate and complete response that was comparable to fellowship-trained ophthalmologists. And in managing glaucoma retinal diseases, in our cross-sectional study, it did show that, based on this blinded graded using Likert scale, that that large language model ChatGPT-4 was proficient and largely matching, if not in some ways outmatching, glaucoma retina subspecialists. But our conclusion here is essentially that yes, in some ways, large language models have been comparative or even outperformed in some aspects. A seasoned clinician was still going to be better in a lot of ways and can perform better than ChatGPT-4. And large language models, CNNs, artificial intelligence, big data, it is ultimately going to be the key to unlocking these long-standing questions that we have in ophthalmology, whether it be screening for early glaucoma, understanding and predicting OCTAs and ROTA or genetic risk scores. Large language models is one of the big keys for deciphering all the convoluted data that we have. And my talk here is not to say that large language models or artificial intelligence will replace ophthalmologists, but really that it's going to help with screening and essentially helping with the prediction models in helping us better identify the patients that need our care. Okay, thank you.
Thank you.